Dr. Noyes wanted me to share with you the definition of theosophy. Several people had asked him, what does theosophy mean? We know what theology is, we know what philosophy is. It's an interesting combination of words. Theo means God, and Sophie means wisdom. So this has to do with the study of divine wisdom. It's a term used to describe esoteric and mystical beliefs that describe the relationship of human beings to the universe and the Godhead. Theosophy, divine wisdom. It describes esoteric and mystical beliefs that describe the relationship of human beings to the universe and the Godhead. These belief systems may describe emanations from the Supreme God who reveals different aspects of transcendent reality through various intermediary deities, spirits, or intelligences. And I can let you hold on to that sheet there. It's in his book, and so in his glossary of terms, when you get his book, you'll have a definition of that, plus all other terms as well. I just talked to my wife in Fort Worth. She says it started snowing this morning about 7 o'clock and snowed right up until about 5. They had a passion play down in Keene with several outdoor scenes that repeated themselves, and everybody got cold and wet and the like. And so we have cold weather there as well some of the times. Tonight, I have one Bible text and no quotes from Spirit of Prophecy. But I want to tell you a little bit about my experience when I was with the Surgeon General's office on smoking and health. I was the medical director of the Office on Smoking and Health, and my job was to write the Surgeon General's report on smoking and health. They have a report every year, and they had a library that collected all of the world's literature on tobacco that emerged during a 12-month period, and they had that in their library, and we get an actual hard copy of that, and on the average there were about anywhere between 1,700 and 2,000 scientific studies on tobacco that were published every year. And my job was to read them all. And once I read them all, knowing what was in previous Surgeon General's report, it was my job to decide which articles were relevant and which articles were not relevant. And then to write chapters, one on cancer, one on heart disease, one on lung disease. We had one on pregnancy, one on exercise, one on pipes and cigars. And to write chapters based on the articles that came in. It was a great education for me. I learned to read an article and to tell how the study was designed and to tell whether it was a good study or a bad study. Sometimes I'd read a study that looked pretty good, involved a whole lot of, I'll give you one concrete example. There was a big study done by a Dr. V.J. Reddy in India, and it looked at the use of tobacco and betel nut. And betel nut's not good for you, neither is tobacco. And in his study, he did it in such a way that he had some people that were smokers and some that just smokers alone. And then he had some that were smokers and used betel nut, and then he had some that used just betel nut alone. And it was a study of oral cancer, and there's a lot of oral cancer in India. And it would have been very nice if we could have isolated how much of it was due to tobacco and how much of it was due to betel nut. He lumped them all together and just gave us a number. And it involved 25,000 people, and it was a huge study. But after studying it really carefully for a couple of days, I realized it was totally worthless because I could not isolate the independent contribution of tobacco to oral cancer. And so we had to assume that, yes, some of it was due to tobacco, but some of it was due to betel nut. And the article was only going to be of interest to me if I could isolate just the contribution of tobacco, because that was my job. And so you quickly learn to look at studies and to study them very carefully. And so I'm going to talk tonight about how we might scientifically approach various kinds of problems and to tell you a little bit more about science. This is the text that I want to give you tonight, and it's from 1 Corinthians 14:40. let all things be done decently in order. Miss White says order is the first law of heaven. Everything in heaven is done extremely orderly. So when you go home, if your sock drawer looks a little messy and you want to get ready for heaven, put it in order. Because order is the first law of heaven, and we should do everything decently and in order. I ran across this article, and I'm just giving it to you just as it comes from the article because I thought it was so good. And it's by Robert Park and published in the Chronicle Review in January of 2003. And he's gotten a lot of flack for this article, but I thought it was beautiful. And it's 7 warning signs of bogus science. And so we're going to look at this article, and I'm going to give you the seven signs. And one sign that something is bogus science, if it goes directly from the discoverer to the media. Focus Factor. The guy that gives the ads for Focus Factor is the guy that invented Focus Factor. And he tells you that he uses it, and it's made a wonderful change in his life. I'm sure it has put a lot of change in his pocket, but I'm not sure that it's worth much more than that. Well, the point is that the integrity of science rests on a willingness of scientists to expose new ideas and findings to the scrutiny of other scientists. It's based on honesty and trust. Now, are there dishonest scientists? Yeah, they are, and we catch them quite frequently. But bypassing peer review suggests that the work is unlikely to stand up to close examination by other scientists. Makers of some products go directly to full-page advertisements or to infomercials. And if you notice that they'll say, I invented this, and now yesterday and today I'm selling it, that's bogus science. Because he hasn't done any studies, he doesn't have any animal studies, he doesn't have any chemical studies, he doesn't have any efficacy studies, he doesn't have any safety studies. Nobody else has looked at it, nobody else has examined it. It's bogus. Number 2, the discoverer claims suppression by a powerful establishment. The claim is that the establishment suppresses discoveries that might shift the balance of power or wealth. They accuse mainstream science of being part of a larger conspiracy that includes industry and government that doesn't want to upset the status quo. I hear this all the time. As you know, I practice medicine with people who have HIV and AIDS. I have 700 patients in my practice. All of them have HIV and AIDS. And at least once a month, somebody says, but somebody actually has a cure for AIDS, but they don't want to let it out because the drug company is making so much money off of these expensive drugs that if they cured everybody, they would go broke. And so it's a conspiracy, and the government keeps it down, and they're in hands with the pharmaceutical industry. That's just illogical argument. I mean, if I had a cure for AIDS, I would be a billionaire tomorrow. I mean, I really would. And the truth is, there is so much competition in the pharmaceutical industry that if any pharmaceutical company comes up with a cure for AIDS, I'll guarantee it'll be on the market as soon as possible, and they'll get the FDA to give them early approval on it. And it'll go worldwide, and they'll become a billionaire company. So, the government doesn't suppress anything that has value, and the industry doesn't either. So if a discoverer says, well, I could have gone worldwide with this. This is a really important product, but I've been sabotaged by the pharmaceutical industry. I've been sabotaged by the government. If you hear that kind of a story, it's bogus science. It's not real. Now, this is another one. The scientific effect is at the very limits of detection, which means it's really hard to tell. Like there are no clear photos of flying saucers. They're always fuzzy. And you may have remembered the Loch Ness Monster. And that was, there were photographs of Nessie. But they were always kind of fuzzy. You really couldn't tell what it was or where it was, and so on and so. And finally, on the deathbed of this guy, he admitted that it was a hoax, and he was really fooling everybody. And I think he took a picture in his bathtub or something like that of a toy that was out of focus. Anyway, scientific measurements must contend with some level of background noise or statistical fluctuation. This is always true. When you do an electrocardiogram, you're measuring electrical activity of the heart, And we're looking at millivolt, a thousandth of a volt activity. Well, in order to measure that, you've got to make sure that everything is grounded and shielded. All the wires are shielded, otherwise we'd get enough current irradiated from the fluorescent lamps to make this thing jump all over the place. And it would look just horrible unless everything was grounded properly. So if we ground everything properly, get the sensors tuned just right, hey, we can measure electrocardiogram. We can measure the electric things in the brain. There is nothing that moves that we can't measure. But people will tell you, oh, this is, you can't, nobody can measure it, but you can feel it. Well, if you can feel it, but you can't measure it with an instrument, that's bogus science. And as the scientist says, the signal-to-noise ratio can't be improved. If it can't be improved to the point of detection, it's probably not real, and the work is not science. Another one is the evidence is anecdotal. Anecdotes have a very strong emotional impact. It helped me. I'd never argue with anybody that was helped by anything. I have patients that have done the weirdest things, and they got cured, or they felt better. I said, well, great, I'm glad for you. I'm happy. That's great. I'm glad you're better. Don't argue with that. But you can't generalize from that person to the whole population. Just because it happened to you doesn't mean it's going to happen to the rest of my patients. Come on, I'm not going to base my therapeutic decisions on the recommendations of a single individual. As Dr. Noyes said last night, Eve ate the apple on the recommendation of one anecdotal evidence. It was snake oil. And it was the first supplement. I just love that. It's really, really a beautiful illustration of the fallacies of using anecdotes. Anecdotes keep superstitious beliefs alive in an age of science. And this next statement, if you remember anything tonight, remember this one. The most important discovery of modern medicine is not vaccines or antibiotics, but the randomized double-blind test. We know what works and we know what doesn't work. So what is a randomized double-blind test? You know what a double-blind test is? A double-blind test is a test where you have a pill that you're trying to test to see whether it does any good or not. And so you make up the pill in its actual factual form. Then you make up some pills that are placebos that look just exactly like it. And then you enroll physicians to take part in the study, and you enroll the public to take part in the study. Now, they have to have an informed consent. They need to know what the pill is for. They need to know that they may get the real medicine or may not get the real medicine. And the doctor who is administering the pills does not know. And the patient does not know. And so if the doctor doesn't know, now he might be enthusiastic, but guess what? He'll be enthusiastic for the drug and the placebo. A doctor may be skeptical, but he'll be skeptical for the real drug and for the placebo. So the doctor effect is canceled out that way. And if the patient doesn't know, and they might say, oh man, I feel an awful lot better. And they might be an optimistic patient. Well, optimistic patients will get the drugs, and some optimistic patients will get the placebo. And so when you ask them how they're feeling, how they're doing, and you have thousands of participants, then you crack the codes after it's all done. You see if it's real or not. And a lot of times studies are terminated early because there are bad effects that have happened. Sometimes they're terminated early because the effects are so good that they don't want to withhold it from the population at large. But until you have a double-blind, randomized trial, you don't know if anything works or doesn't work. And there just are a lot of people that don't want to submit their products to this or their procedures to this, and the world is not better off if that's not done. And I thought the last point was good. Data is not the plural of anecdote. So you get 2 anecdotes, and that makes data. You get 3 anecdotes, that makes data. You get 500 people that endorse something, that's still anecdotal evidence. That's not a test. Just because you have 500 people that endorse your product does not mean that it is real. Data is not the plural of anecdote. Some people say this is credible because it endures the centuries. I had an uncle name was Earl Zimmerman on my mother's side. Faithfully raised and ate ginseng all the time. So I said, why are you into ginseng? And he said, 1 billion Chinese can't be wrong. And I thought that was kind of an interesting answer, but that does not make it credible. There is a myth that hundreds or thousands of years ago our ancestors had miraculous remedies that modern science can't understand. Just not true. Ancient folk wisdom, rediscovered or repackaged, is unlikely to match the output of modern scientific laboratories. It just doesn't happen. If all of that was so good, how come their life expectancy is so low? How come their life expectancy didn't get better until they understood hygiene, clean water, sewage systems, and modern medicines? We've doubled the life expectancy of these countries that have these ancient cures. Ancient cures are worthless. 6, this discoverer has worked in isolation. The image of a lone genius who struggles in secrecy in an attic laboratory and ends up making a revolutionary breakthrough has more to do with Hollywood fiction films than with reality. Scientific breakthroughs today are almost always the synthesis of the work of many scientists. It's really true. The kinds of problems that we're working on today are really at a molecular level, and it really takes a team to produce a product or a concept or idea. It takes many, many people working together. And if this has a person's name attached to it, chances are it's not any good at all. In science, we don't put people's names on anything anymore, because by the time it's been validated, so many people have been involved, so many universities have been involved, that we give a name to the process. Now, sometimes scientists will patent some aspect of it to try to make themselves rich. And, of course, you know what I think about doctors and money. I told you this morning. And this, I think, is important and hinges on what I talked about last night. The discoverer must propose new laws of nature to explain an observation. A new law of nature invoked to explain some extraordinary result must not conflict with what is already known. If we must change existing laws of nature or propose new laws to account for an observation, it's almost certainly wrong. I told you we're trapped in 4 dimensions. And that's where we live and exist and have our being. And that's reality. So if you come up with another explanation that, oh, listen, there is a second level that's a little higher, or a third level, or there are 7 levels, nobody's seen them, nobody's understood them, nobody's matched them. We're stuck in 4 dimensions. If they have to propose some new laws, it's bogus science. Well, those are the 7 things. I thought it was kind of interesting, and I thought it was helpful. So now I'm going to talk a little bit about scoring and grading. And what I'm proposing is an evidence and spiritual-based rating system. What I'm suggesting is a way to judge a treatment modality. And what we might call it would be a therapeutic practices and products committee. The U.S. government has a Food and Drug Administration. And in spite of all the mistakes that they make, they've saved us from many, many poisons that people have tried to foist on us. And they have recalled a lot of drugs that in the long run have shown to be ineffective. But they've licensed a lot of drugs that save a lot of lives as well. And I think that my proposition would be is that our church, Seventh-day Adventist Church, in order to prevent bogus things from being foisted on us, we really ought at some level, either at division level or general conference level or union level, have a committee, a therapeutic practices and products committee. And the interesting thing about it, it would be composed of scientists that could be tapped, that are in a similar discipline to the question modality, and then a panel of church representatives. It should include health secretaries, should have some pastors and administrators and some local members as well, some lay members. And the process would go this way. The process to start off with would be to define the relationship between a procedure and a disease state. So we can say, well, what are we treating? What is the disease that we are treating? What is the condition that we are treating? Are we looking at one condition? Are we looking at 5 conditions? Are we looking at 10 conditions? Then what is the procedure? How will the procedure be standardized? Who is going to do the procedure? How long does the procedure last? So you start off by defining both the procedure and the disease state. And it's basically asking, what is the procedure or product supposed to do? And this guides us as to what studies to choose. Once we know what we're looking at, then we can collect relevant scientific studies. And I think as a church, we should not be embarrassed. We are not embarrassed by science. We endorse science. We like science. Science helps prove things. Science can't prove God. Science can't prove everything. But in its realm, science is good. And then what we ought to do is, once we collect the studies, we need to classify and rate the studies as to what type of studies they were. Once we've done that, then we can analyze the data. And then we can rank rank the procedure or product and give it a score, give it a grade. And say the Seventh-day Adventist Church, their product and procedures committee has examined this product. We've looked at the scientific evidence involved. We've consulted with our theologians, and this is our conclusion. And once they do that, it's decided. And it's decided for the world church. That way we can help. We do this doctrinally. We got 28 fundamental beliefs. They get a butt of a lot of jokes sometimes because we're only saved by the blood of Jesus Christ, and I believe that. But 28 fundamental beliefs are extremely useful, and they keep us homogenized around the world. I mean, you can go from country to country, and Catholics, my sakes, they're absolute heathens in one place, and they're saintly robed people in another. There is so much variation within the denomination. And I think that since we are inundated with many different kinds of products and procedures, there really should be a standardized way of dealing with them, and science could certainly help us with that. And once we've given a grade to a product, then we should educate the church. And once the church is educated, then as far as I'm concerned, the issue should be closed at that point in time. And so what kind of a rating system would I propose? Well, I would use 4 separate rating systems, and I'm going to discuss them briefly. We're going to have a rating system for study design, study quality, the strength of the entire body of evidence from a scientific point of view, and then a rating system for support from Scripture and spirit of prophecy. Once we have looked at that, then we'll come up with final recommendations or a rank based on the totality of the evidence. Now, the study design issue, there are studies that are good and there are studies that are bad, and having been in the habit of reading thousands of studies every year, I can tell you that I would suggest these types of studies. A type 1 study would be a randomized controlled interventional trials. Those, to me, have the highest value. Type 2 studies would be prospective observational cohort studies that are not the same as randomized. They don't have randomization in them. They don't have as much control to them. They are prospective, which I like, and they are observational cohort studies that you study over time. That's a type 2 study. Still a very strong study, and the Seventh-day Adventist health study, and I hope you've signed up. I've signed up, my wife signed up. Adventist Health Study is a type 2 study. It's a prospective observational cohort study. Then we have type 3 studies, which are non-randomized interventional trials, where you just take the next 100 people that come in, nobody's randomized, take them as you come. And the way you try to make it a little bit better is to have a control group that you can compare with. But of course, your control group has to match by age, occupation, race, all kinds of things. And these studies, it's always hard to get a control group that's exactly the same. Then you compare the rates in the 2 groups. And they're not bad studies. And for some diseases, for extremely rare diseases, case control studies are a lot better. Type 4 studies would just be cross-sectional studies where you just go out to the community, find out how many people have one thing or another. What does that mean? Doesn't mean anything. It just means that your community has X amount of something in it. What do you do with that? You know? Case series. A doctor has found a rare tumor of the pituitary. In over 35 years, he found 5 of them. So he publishes a paper saying, I found 5 pituitary tumors. And this is what the symptoms the people had, this was their age group, and so on and so forth. What does that mean? It means nothing. So the guy, all it means he had 5 tumors, 5 pituitary tumors. It's relatively worthless, scientifically speaking. Or analysis of secondary disease endpoints and trials. This is a very interesting, and what happens here, and I see this all the time in HIV studies, is they'll do a big trial, and the trial will prove the point that they tried to make, but then somebody does a sub-analysis of some other symptoms or some other aspects of the product, and then they bring that around and tell you, look what we found. And you say, well, was that the study? No, this is an analysis of a subgroup within the study. You know, well, okay, sure, fine. You know, that wasn't the purpose of the study, though, was it? No. That was an accidental finding, wasn't it? Yeah, well, if it's an accidental finding, it doesn't cut a whole lot of mustard with me. I'm sorry. You know, if you think that's a real effect, design a study, go do it, and come back and tell me in 3 years, and I'll believe you. But don't give me an analysis of some secondary endpoints in the study. So you see what we're doing here is when we collect studies, we then classify them as to studies that are really good and well-designed, that have enough people in them to make them really good. Now, the Adventist Health Study is good because they have 100,000 people. They only have 85,000 so far, but they're aiming at 100,000 people. That's a really strong study. Now, it's not as big as the Hirayama study at 218,000 people. Not as big as the American Cancer Society study. ACS2 study had 1 million people in it. And so, you know, if you're arguing with somebody that says, I had 15 people that did this and they really felt good, I'll say, yeah, but how did it work on 1 million people? Okay? We have 1 million people studies. And we can look at it, we can tell you. So if you're trying to convince me, let's get a good study out there and really show me. And if you can't show me, hey, it's bogus science. Then what we would do is we would look at study quality issues. So we would look at the study and we give it a plus sign if it adequately addressed inclusion and exclusion criteria, if it addressed biases that we recognize, if it had adequate data collection, analysis, and if it had general applicability. So if a study had all of those qualities, we'd say, whoa, that's a high-quality study. We really like that. If it contains some uncertainties about various scientific qualities, we'd give it a and if it does not address issues of scientific quality, it gets a negative. And then there are some studies that people bring forward. We're studying apples and they bring an orange study, okay? And you don't mix apples and oranges, so that would get a does not apply because it's not a part of the body of evidence that we're looking for. And so that study would get a big NA on it. And I can tell you, out of the 1,500 studies that I would review every year, 1,000 of them would have NA written on them, okay? So there's a lot of trash being published. Just because you get it in published in an article or a journal does not mean that it's necessarily a good one. Next, what we would do would rate the strength of the total evidence, and we would look at the quantity of the studies. How many studies are there? And if there were several studies of type 1 or 2, we'd give it an A. If there were several studies of 1, 2, but mainly 3 with some uncertainties, we'd give it a B. And if the studies were all kind of a poor design studies, we might have 50 studies, but each one only had 6 people in it. Well, that's pretty weak. So we'd end up classing that. We just don't have enough good quantity of studies. Then, well, another very important thing is consistency. If you found the same result in your type 1 and 2 studies, that's pretty positive evidence that this is real science. But if you had moderate consistency across all studies, you'd give it a B, and if you had inconsistent results. And I can tell you that coffee drinking studies are very interesting. Half the coffee drinking studies will tell you that it's good for you, half the studies will tell you that it's bad for you. It's totally inconsistent, you know. And now if you look at the Adventist Health Study, coffee's bad for you. and it increases your risk of colon cancer by 30%. It does a lot of really bad things for you. And my theory is that if you have somebody that's smoking 2 packs a day, eating beef every night at supper, a cup of coffee makes no difference to him whatsoever. Okay, this guy's already on a deadly lifestyle, and a cup of coffee means nothing. But if you take Adventists, who by and large are living really healthy, and you got somebody who drinks 6 cups of coffee a day, it's going to show up pretty bad for him, you know? And so it depends on who you're studying, how the results turn out. But yeah, there are a lot of inconsistent results among studies for various reasons. And then what we would do is rate the strength of the total evidence, the relevance to the impact of disease. What we would say is that it would get an A if the magnitude of effect is physiologically meaningful. If we say these studies, now that we've looked at all of these studies, this really has an impact on the way people live and their lives and their restoration. We'd give it a B if there was some suggestion of a physiologic effect, but some uncertainties remain. And we'd give it a C if it's not likely to have a physiologic effect on humans. Okay? Then what we would do is submit this to the theological panel, let them take a look at it. And if it has support in the Bible, hey, we like that. As support in spirit of prophecy, we like that. If we only found support in church tradition, we can say, well, you know, we've had Adventist churches that have done that for 30 years. Well, how strong is that? Well, it has some strength, but not very much. If it had support of theologians, we'd think that's probably pretty good. Church administrators, maybe a little less. Lay members, doesn't make it valid. If there's no church support at any level, hey, we give up on that one. So the final recommendations that I think should come out once this whole process has been done is we'd come out with an A, B, C, D, or E. A would mean a strong support, B would be moderate support, C would be no conclusive support. We're withholding judgment. This is something, there's just not enough evidence, we just give it a C. Or D, we would say we don't recommend it. Now there might be an exception, but this is something we really don't recommend. And we might say E, this should never be used. And once you've gone through this process, if the church and the theologian says this should never be used, that should be good enough for everybody. It's good enough for me. So let's take a look at it. Does the church support drug therapy for AIDS patients? Well, what kind of scientific support do we have? We have some wonderful clinical trials. They're all type 1, type 2 trials. They're very, very good trials. Involved hundreds and hundreds of people. And there are literally hundreds of trials. And we have lab results that are very convincing. When you use these drugs, the virus disappears from the bloodstream, your immune system improves, looks really good. All of the experts are jumping up and down, saying this is really good. So we got some really strong support here scientifically. Do we have theological support? Well, Jesus went around healing. We have advice to do what's good. Spirit of prophecy, we might put a plus or minus on that. Miss White speaks against drug use, doesn't she? Drug use is bad. But I think she would endorse AIDS drugs because they save lives. We have church traditions about doing good. Theologians support it somewhat. Church administration would support it. We probably have lay support. So adding all this up together, we'd give it an A. So the church recommendation is we have a strong support for drug therapy for AIDS patients. Now let's take a look at iridology, which is a study of the iris. They can look in your eyes. They can tell by your iris what's wrong with your gallbladder, your pancreas, your kidneys, your big toe, and most anywhere, as if your whole body was reflected in your eye as a diagnostic tool. Scientific support, no clinical trials, no supporting labs, no animal experiments, no scientific support. Yes, there's anecdotal evidence, a lot of it. And we have a lot of opinion from non-scientists, but we've got category 4 and 7 support, which is pretty low on the scientific scale. There's no biblical support for iridology, no support in spirit of prophecy, none in church tradition, no clergy support. Do we have lay support? Yeah, we have lay members like iridology. They use it. Pretty weak, isn't it? So here in the church side, we got almost no support. On the scientific side, we have no support. So once that went through, what would we get? E, should never be used by church members. Does that kind of make sense? And my feeling is that as a church, we should establish a mechanism for looking at this. I think it would really relieve the stress off of individual churches, off of pastors, off of conferences, off of unions, off of divisions. It would take an investment. This kind of stuff should be fostered by the Health and Temperance Department or the Health Ministries Department of the General Conference. It could really be done under their auspices, because there are similar kinds of issues that come up all around the world. And the truth is, this should really be addressed at a bigger level. And if it's not, then we have to address it at conferences like this. And I think we've had some good dialogue. And we've been frank, we've been open, we've been honest, we've been Christian about it. But the truth is, this isn't going to have a bit of effect in California. Conclusion. A grading system should be agreed upon by appropriate medical and spiritual leaders. All unusual, suspect, or alternative to mainstream health-related diagnostic or therapeutic modalities that interest church members, clergy, or health practitioners should be submitted to a review panel for a judgment regarding their appropriateness for use by Seventh-day Adventists.